And Dr. Webb, whenever you all get settled in, you are recognized and are good to go.
Is this one on?
Yeah, so
Okay. Got your presentation up.
Oops. When you're ready.
Voice working, sure. Good afternoon. I am Joseph Webb, CEO of Nashville General Hospital, and I have here with me Dr. Bruce Narramore, who is our Chief Financial Officer. We will be going through the budget items with some commentary, and after which I assume we will engage in some Q&A. So we'll go ahead and get started if that's okay.
Good evening. Thank you guys for joining us this evening. Our initial 2025 budget and support request was approved in February by our Hospital Authority Board, and we anticipated there could be some changes from that request before we got final approval by the board in May or June when we get there, in partnership, obviously, with Mayor O'Connell and the administration. We had requested $63.8 million of a $154 million budget to be supported in furtherance of our mission to serve as a city safety net hospital. The current recommendation from administration came in at 59.55. So that's about a 3% increase over what we receive or will receive in 2024. And we're working diligently. We think we've found as best we can the way to make that budget balance at the 59.55 threshold, but not without a good bit of pain. So we'll get into that. So let me see if I hit this. So the Metro Charter, we have a lot of tenured council members here that know what the safety net hospital is, but we also have some newer members on council. And I just want to say the charter still requires the city to operate a hospital to care for Davidson County residents who don't have access to medical care or are charity or uninsured patients. Now, 8 years ago, we were about 50% insured and 50% uninsured. And this past year, or the year we're in, we're at about 61% insured patients and 39% uninsured. And that, that off-site clinic growth has helped attract insured patients to the system. We are celebrating, or we just celebrated our 134th year in operation, believe it or not. It started with one doctor and 7 nurses 134 years ago. We are still the index teaching hospital for 4 of Meharry Medical College's residency programs. We also host residents and faculty from Vanderbilt and some other schools in the region. What's cool about the hospital is our patient population is extremely diverse, as is our workforce, and that makes us, popular with research entities, whether it's Vanderbilt, Meharry, or pharmaceutical companies, which is a really nice part of having a diverse population at the hospital. So this is just a brief review. The budget that we had approved last year, we were going to generate $58.5 million of our own patient collections, and then $57.8 million coming from the city's support of our mission. And so a total budget of $133 million. Now in 2024, the hospital, we finally cracked the code and we got a very substantial supplemental pool payment, which is a program the hospital has been in for many years with the other public hospitals in the state. but we also, for the first time, are receiving state disproportionate share funds in substantial amounts. So that's what really helped float us this year. We also, if you see under the TennCare MCO, that number 5, this year we got 3.5 million over the course of the 9 months for the managed care organizations under TennCare that made payments to all hospitals, not just Nashville General, because they understood that Medicaid payments had not risen in a long time, and hospitals were all experiencing extremely high costs. And so that was something, I'm sure it was federal funds, but the state sort of pressed for them to do that. And we did benefit from that one-time funding from each of the MCOs. It was around 700,000 or 800,000 each from each of the plans. So that helped us in the year we're in currently. So the budget for 2025, I just put it in 3 columns there. The first was where we project to finish for this year. And you can see about 151.7 million of revenues. And then the budget for 25 that we submitted back in March was 155.5 million. That presumed a $63.8 million support payment from Metro. And then we've had to modify that based on the recommended numbers from administration. We believe we'll still bring in $61.1 million of our own money, self-generated, and then 31.7 million from state and federal sources. I did add back graduate medical education. We did receive it in 2023, which was the first year that the state paid graduate medical education directly to hospitals. And so we received 1.1 million in 2023, but unfortunately in 2024, we were unable to qualify. We were unable to get the resident rosters that we needed from the Meharry Medical College in time to qualify. We do believe we have them to file this July 1st, and we do expect that we will recover in 2025 budget that 1.1 million. Understanding, though, that with that 1.1 million, it is, at least part of it, will end up being paid back to the medical college in support of residency programs. Requires an amendment to the PSA, but we do expect to get that revenue, and we expect that we will pay a substantial portion of it out to the college. And this is just a brief look, because I think when you hear you get 59.5, how much of it really is available to take care of patients that present to us. The building that we're in is still a $4 million a year lease. The parking garage is about $70,000 a month, plus we pay a $20,000 a month stipend for patients to park there, to the SP3 people that manage the garage for Meharry. And then we have the 5.9 million that was paid intergovernment transfer, where the city actually matches money from the state, and that's how we get that supplemental pool payment. And then the legacy pension, this is a long sticking issue for us. The hospital authority was handed the pension cost for the Bordeaux and Knowles facilities several years ago, and we still carry that burden forward. $2.4 million of our subsidy or support payment is for handling that. And then the other one is security. Back in the old days when the hospital was part of Metro, the sheriff's office provided security. And when that changed, 2011, I believe there were about $800,000 that were put into Metro Nashville General Hospital budget. And we actually paid that money to the sheriff's office. And then at some point that money was transferred to the sheriff's office, and we picked up the private security contract. And so that's right now about a $1.3 million a year cost that we've taken on about 3 years ago that was sort of unanticipated in the budget year that it occurred. And then just a little bit of history, and this is not picking on anyone, it's just that the history between the hospital and Meharry was that when Mayor Barry announced the plan to close inpatient services at the hospital, and Meharry was going to transfer their residency programs to the HCA facility down south, it ended up being taken back, or it didn't come to pass. But unfortunately, in that 6-month time period before it cleared, it was almost 30 physicians left Meharry just out of fear for their, well-being, continued employment and so forth. And that was a third of the active hospital medical staff for us at the hospital. So general surgeons, the vascular surgeon, both orthopedic surgeons, their internal medicine faculty, 2 key hematology oncology physicians, the ENT physician, the ophthalmologist, endocrinology, and some other subspecialties. So that's just what happened, and it's had significant impacts for both Meharry and for the hospital since then. So since then, we, the hospital, have had to hire those replacements, basically mostly salaried employees. And so we have recruited 2 full-time orthopedic surgeons, 2 urologists, an interventional cardiologist, and 2 general cardiologists, 2 general surgeons, an ophthalmologist and an optometrist, 2 podiatrists. We've got several net new primary care MDs, a full-time gastroenterologist, and then we did recently hire the MD oncologist and the nurse practitioner that when Meharry discontinued oncology service, we actually hired their physician and their nurse practitioner. We have a 76-year-old accredited cancer program, one of the oldest in Middle Tennessee. And then in February of this year that we're in, we did take over and employ 2 new primary care physicians down in Metro Center who have really busy practice. So this is just sort of this is the ballpark when you look at 3, 4, 5 years ago, what salary expenses were in the hospital, and then you recognize that we started employing physicians out of necessity back in 2018, 2019. And so you can see the annual spend just on those physicians, not the staff that supports them, but just the physicians themselves, is a little over $9 million. And we do generate a good bit of patient revenues from those physicians, certainly. But when you look at just year-over-year increase in salary expenses at the hospital, this is a big impactor. And then this is just sort of a view of the last 8 years. And yeah, I was here for all of them. Dr. Webb was too. So this is just sort of a run. In 2018, we received $52 million of support payments from Metro. In 2019, it dropped to 46.1, and that was acceptable. It worked well for us at that time. And then 43.1 in 2020 fiscal, and then everybody knows what happened in fiscal 2021. That was the start of COVID. We did receive some federal funds that allowed us to weather through that year. But then in 22 and going forward, you can just see the costs have gone up pretty substantially. Healthcare costs, I just heard Dr. Wright having conversations about the staffing issues they have, and we're in the same boat trying to recruit nurses and clinicians and ancillary service people to work at the hospital. It's a very competitive environment. So, but even if you average this out, if we had gotten what was requested, it would have meant that our average increase since 2018 was 2.9%. which is pretty low for a hospital, a healthcare system. And if we are limited to the 59.55 and we stay there, then it's a 1.9% increase over those 8 years. Next is this is usually Dr. Webb's stuff, but he's better at this stuff, the celebrations.
Yeah, we do put ourselves in a position to provide excellent care to our patient population. And we like to think that we represent the science of healthcare delivery because we do use evidence-based methodologies for our caring for our patient population. we have the TNCPE Achievement Award. We're at level 3. We're working on level 4. Level 5 is as high as you can get, and that's based on performance, commonly referred to as a Baldrige Award. We are accredited by Joint Commission, which is the accrediting body for 90+% of hospitals. It is also deemed status for Medicare participation. If you don't achieve Joint Commission accreditation, that calls into question whether or not you're really going to be a viable candidate for receiving Medicare reimbursement. NCQA, National Committee for Quality Assurance, we are at the highest level under our patient-centered medical home there. That is an accomplishment. That is for our primary care clinics. And we're in pursuit of that same recognition for our specialty clinics. We are also accredited by the Commission on Cancer Accreditation. And that is, I think you said 76 years. I think it's about
80 now.
Yeah, it's 81, I believe, years that it is the second oldest in the city. Excellent program. And we also have the NCQA recognition for diabetic care under the National Committee for Quality Assurance. Quite a few of our patients struggle with that condition, and so it is something that is good to have to keep them out of the emergency rooms and out of crisis.
So, yeah.
Okay.
I was just going to add that because I heard Dr. Wright was in here earlier, and I don't know that everybody understands that the hospital operates an adult sexual abuse program where our medical legal examiner nurses go out to hospitals all around Nashville, and we've had it for many years. And so it's the same program is operated within the city as well. But a lot of those patients are sent to our hospital to be examined, but our nurses also go to those outlying hospitals, large hospitals in some cases, and do those examinations. And those hospitals actually pay us about $35,000 each per year to be part of that program. So it basically breaks even. It's a really great service. And then many of you probably are aware that the Our Kids program for sexual abuse of children has been a long-standing part of Nashville General Hospital. Even though they're located around the corner on Hayes Street, they work very collaboratively. So I know the Public Health Department tries to take care of those things before they occur, but when they do occur, Nashville General Hospital is key to that process for both adult and child sexual abuse. And then just, I know there's been some checkered history or issues historically with the hospital, but we have had clean audits for the last 6-7 years. Our job is to care for the most fragile while trying to grow services, backfilling by necessity in some areas if Meharry moves away from a service and focuses just on teaching, which is understandable. And then we're just working to attract more insured patients. We're also, many of you know that we have a locked 7th floor where forensic patients can come. We have the Metro patients that use that floor. Unfortunately, we don't get reimbursed for those, but for the state prisoners, we are reimbursed, and we're reimbursed well to take care of those patients. And that's a big chunk. That's about 15% of our collected revenue. So, when the state has to send patients in for care, whether it's oncology, surgery, GI, or just clinic visit, we have that ability at the hospital on the 7th floor where they need fewer security personnel because it's a locked floor, so they don't need to send so many security with those incarcerated persons that need care. And, our nurses, they do a really good job of taking care of those people and making them feel welcome. It's a good business for the hospital. And if we do get to a new hospital, I would make sure that we have a floor or two that's committed to taking care of them, just preferably with its own private entrance so they don't have to mix in with the general population of insured patients that we're trying to gain favor with. Next is just some thoughts about sort of cost impacts that have happened since COVID sort of hit. I know it was almost 4 years ago when it started, but nurses have retired in force. I have a 24-year-old daughter, ICU nurse, not in Nashville, unfortunately. And, you know, she's been 2 years and she's probably the most tenured person working at the Duke Hospital right now in the ICU. It's just amazing how many 50-plus-year-old nurses have just decided that they don't want to work in that field or work on the floors anymore, and they've moved into other spots. So nationally, it's 5 or 10% of the RN workforce left, retired, they're teaching, they're doing something else. And then the other issue is, if they did retire, the nursing schools do not have the faculty to gear up the need for the new students. I would just say our chief nurse, Veronica Elders, does spend a lot of time teaching. I mean, she doesn't have time to be a full-time faculty, but she does teach. She's also in a doctoral program herself. She's a great model for all nurses to follow, and I would encourage people to look at Nashville General as an option. We have backfilled positions with new hire incentives. We got referral incentives. We got our own nurse residency program that graduates 6 or 7 net new RNs every 6 months, but keeping them is the challenge. We can bring them in, but as quick as we bring them in, they want to go travel somewhere and make $70 an hour instead of the $35 that the hospitals are willing to pay in this market. So it's a challenge. Just to go back to pre-COVID, our contract labor costs in 2019 were $2 million. And for the year we're in, they're projected at $13.2 million. And right now we've got 60 nursing positions that are open. We have about 75 positions in the hospital as a whole that are open. And when I say they're open, we're recruiting for full-time staff. But we have those contract nurses filling those spots because Joint Commission and others require staffing standards, that you meet staffing standards in acute care areas. So it's a challenge for us. It's the largest financial challenge, I think, for the hospital. And then, as I mentioned earlier, Mary has, they have a new provost in, and I think she has reached out and tried to help us get all the rosters in place so that we can file and get some GME back into the hospital for 2025. And some of those funds, as I said, would be paid to the college with an amended PSA. We are talking about reducing some consultant and contract staff spending by about $800,000. We need to hire, so we lost some key people to retirement, a couple in the last 12 months, and quality directors, infection control leaders, medical staff leaders. We just got our new revenue cycle leader, and she's a big hit, but it took a while to find her. But if we can not use interim people that are much more expensive and bring our own staff in, we do believe we can easily shave $800,000 off of our costs. We do think that we can, or we could terminate a contract. We're using an outside recruitment resource. It's about $513,000 a year. And like I said, we've had better success recruiting. Our challenge is retaining. It doesn't benefit us if they come in and just go back out in a year. And I think some of that is we need to be a little bit more careful about who we do bring into the workforce. Also, we hired our own rheumatologist a few months ago. By hiring our own, we should be able to terminate a $230,000 per year outside contract for coverage. And we are looking at some other things. We have a valet service that's fairly expensive, but it's a nice patient ad, but it is expensive and it's difficult for them to staff. So we're working through those. We do have a new research division in the hospital, small staff. So we have incurred the cost to bring on some experienced people, but we do think that we're going to generate some grant clinical trial revenues in FY25. We don't have the first trial yet approved, but we have 4 or 5 that are on the books right now that we expect. And it won't be significant, but our administrative fees associated with those trials could approach, six figures or $50,000 to $100,000 a year. And then I know this is an eye chart, and I'm sorry for that, but this is the budget as it's proposed. You can see our projected numbers on the left for 2024. And then the budget for 2025 with the mayor's recommended threshold of 59.55 million. And so the things that I would point that sort of stand out is obviously we have to generate ourselves almost $4 million more of net patient revenue. I think that's achievable. But the ones that are difficult, in that additional state funding, you see it drops from 26 million to 21. Most of that is that $3.5 million one-time payments that we got from the TennCare MCOs. It will not repeat. I would love that it did, but it was paid out of ARP funds and pressed on them by the state due to the just the significant costs and the fact that Medicaid is a notoriously low payer in terms of covering costs for hospitals. And so the city supplement is at 59.55. Our total revenue would be 152.4. As far as expenses go, our salary expenses are up about 6.9%. We hired an obstetrician to help fill out the OB complement with the Meharry Medical College residency program. We did hire a second cardiologist. We have a second oncologist joining us in the next 60 days. And so those physicians are not yet in the run rate and the support staff's behind them. But the revenue is up in that $61 million. So when you factor that in for the full year next year, it's about a 6.9% increase. And for our staff, it's basically a 5% increase for our existing staff. And I know Metro, we're not Metro traditional. We don't have step increases. Our active employees are not part of a pension program. So all our people get is whatever the annual increase is. And so, they work for us. They work for the mission, honestly, and we have to be fair with them. And so, 5%, Dr. Webb wanted it to be higher, but the numbers just right now don't work. So that's the one thing that we might request is we would love to give our staff something more in line with what Metro is able to give their staff this year. But then the rest on the expenses, you can see contract physician services are dropping. Many of you have heard that the cardiology contract at Vanderbilt ended in March. That was about $1.6 million a year. So that's why our physician services are dropping off. Also, we ended a contract, or we're planning to end a contract potentially for the rheumatology service since we have our own provider now. And those are really the big changes year over year for the hospital. That Metro indirect that you see, the 5.9, is flat year over year, and we get that number from the Metro finance team. 3.5 million of it is our own pension and other expenses, and then the other 2.4 is the Bordeaux and Knowles sort of legacy pension and related expenses. So with those changes, we can knock the margin down. It's still a $320,000 loss, but we're still working on it, and that's what I bring to the group today.
Thank you for that very comprehensive presentation. I will go to Public Health and Safety Chair Evans first, and then I will go to Budget and Finance Vice Chair Councilwoman Toombs second.
I guess the question that stands out right now is around the salary increases for the staff members. And so just making sure that I'm clear that if there's a 3.5% cost of living adjustment in the current administration budget, that is all that employees are eligible for? Or are they also eligible for merit?
Yeah, maybe I wasn't clear. We don't have, Metro has a COLA increase and they have steps. So as people progress through the steps, we had that 15 years ago. We don't have that anymore. So the only increase our employees get is the annual increase. And right now, it's still one size fits all. So if you've been here a year, right, then you qualify for that 5% increase, which is what's in the budget. But that's it. There's no step increase. There's no, I mean, you could get promoted, but there is no step increase in our division. And like I said, we had a pension plan. It ended to employees in 2011. And so we still have a handful of employees that have been with us that long that are still part of the pension plan. And we do fund that piece, but none of our employees since 2011 are part of a pension plan. I know Metro has one, but it requires a 10-year service, I believe, to have benefits. So it's just that this is all our people get, is this. And I know it's a challenge because I'm trying to make these numbers fit, and Dr. Webb is beating me. Yeah. So it's just that increase. That's all we have to offer our folks.
Thank you for clarifying that for me.
Sure.
And then I know, I've been going back and trying to watch the hospital authority meetings. And so I know there's been some tension with the hospital in Meharry. And do we feel like we're moving in a good direction on that, or where do things stand?
Yeah, let me answer that. We have reached out, and I know there was a few a meeting ago where there was some information reported at the board meeting. We have since met with the leadership at Meharry, and we have scheduled a bi-weekly, every other week, meeting to continue working through issues with them. Much of the information was inaccurate, and we shared that and showed evidence of where they were presented with a lot of inaccuracies. Unfortunately, we don't get to go back on the television and tell everybody that those inaccuracies occurred. But we're not concerned about that. We're just wanting to make sure that they understand and that we're working towards the relationship that we need to show to the public. So we do have the regular meetings that are scheduled.
Thank you. That's all the questions I have for now.
Thank you, Chair. I'm going to go to Councilwoman Toombs. You're recognized.
Thank you, Chair. I actually have several, but I'm just going to ask a few to start. And I want to piggyback on the COLA question. So all Metro employees don't get steps. Some are
I get that.
eligible for 3% merit raises. So do Nashville General folks, do they get a COLA and a merit raise?
No,
Okay.
just one raise, yeah.
So they're not getting a cost of living adjustment. You're just calling it an increase.
It's just an annual increase,
Okay.
yeah.
I noticed in your budget that you have a line item for repair and maintenance. Can you explain what that is?
Yeah, well, unfortunately, a lot of equipment at the hospital and the building that we occupy, we're responsible for all repairs. So if air chillers go out, if power, basically, we get the building, but everything within it, from mechanicals to electrical to you name it, is a responsibility of the hospital. So within repairs and maintenance, there are real repairs, that we have to pay for ourselves. I think we paid $400,000 for a roof repair that really shouldn't be our responsibility, but we couldn't have it keep leaking into the fourth floor women's services area. So we agreed to split the cost with Meharry, even though it technically was their responsibility.
Well, the lease that the city entered into with Meharry is a triple net lease, which basically means that the tenant is responsible for all repairs.
So we've talked about this in previous budget years about covering capital expenditures in your operating budget and putting those capital expenditures in a 4% fund request. And I know in the past there's a 4% fund request that's coming where I think you're getting like $1.something million.
1.8.
And then for surplus funds for fiscal year '24, you should be getting the $7 million.
And we've already drawn about 3.5 of it,
Okay.
Council Lady.
So my question is, why are you continuing to include capital expenses in your operating budget? Is the administration telling you that these expenses don't qualify for 4% fund?
Well, I mean, first of all, there are two different things. One is a repair, like a major repair. And in accounting jargon, a lot of times those are not capitalizable.
Okay.
That doesn't mean we couldn't get 4% money to cover them, but they're not capital in nature oftentimes. And I don't want to get all accounting on you, but
Could I interject something? I think we need to understand, put something in perspective. The 7 million is, well, actually, that's the first time we've ever received anything like that. But that's against a $20 million budget because of the deprived capital over the years and the age of the plant. And we're operating from that position. So just to put it into context, that's
And,
the relationship that exists with that.
and I want to be clear, and I'm not trying to be argumentative. I want to make sure Nashville General has what it needs. And so I know I've personally asked for an itemization of what that 20 million encompasses so that I could help advocate to the administration. And that has not been received.
I don't know
I
why
apologize for that. I've got
it
it.
exists.
If you could send that to me or to Chair Porterfield, I know
Absolutely.
that's, Nashville General is always a top priority for the Minority
Thank you.
Caucus. So I want to make sure that you're getting what you need. So, because I continue to have concerns about this repair and maintenance and
Yeah.
wondering how much of that could be part of your 4% fund request, and you don't
Yeah.
have to worry about paying it out of your
Thank
operating
you.
budget.
I appreciate that. Council Lady Toombs, could I just clarify, because part of that is annual maintenance, right? So if we have a $1 million MRI machine and it costs $100,000 to keep it covered, that's in that number too. So it's not all repairs.
Okay.
Some of it is maintenance that we pay annually, just like we pay
Yeah.
car insurance or something, right?
Yeah, and I still think it's worth having a conversation just to see
Sure.
what can be moved.
Right.
So looking at your fiscal year 24 budget, and I may have gotten the numbers mixed up, but was it fiscal year 24 that you got the additional funding that you weren't expecting? That it was roughly about $18 million? Did I see?
I
it was
think
on
that's
one of
a
those
little-
slides.
Yeah, I think that's a little
It
high,
was
but
like
it was about 10 million
the-
from the state. Because in the past, they used our certified public expenditure, but they used it to match money to pay all the other
It
hospitals
was
in
the
Nashville.
slide where you showed all the
Yeah.
funding sources. But that was money that you weren't anticipating. So
Correct.
did you make any adjustments to your budget? Are you going to draw down less of the subsidy because of those unanticipated funds?
Yeah. Right now, we're unfortunately tapped out like we usually are at this
Okay.
time of year. It's just our expenses with taking on physicians and so forth is rising. Yeah.
And just for, I know, because we have new folks, with this subsidy, you don't get all of that money up front. You draw it down as you incur expenses, right?
We have a call every week and we look at payables and collections and so forth in detail with the Metro Finance team.
So as bills come in, are you submitting those bills to finance? Like, how do they get
No,
paid?
we actually pay everything. We have our own bank accounts that was set up, I don't know, 13 or 14 years ago. So Metro they would wire funds to our account in support of the hospital as needed when we get into danger zone, I guess, typically. And we do that with those weekly calls, and they've been very cooperative.
Chair, I'll let other people ask questions.
I don't see anyone else in the queue yet. Okay, so we'll go to Council Lady Webb, and then we're gonna go to Councilmember Nash. Does anyone else have any questions? And then I'm gonna go back to Council Lady Toombs. Thank you, Councilor Webb, you're recognized.
Thank you, and thank y'all for coming.
Thank you.
I have a few questions. And every time I hear somebody ask, I get another question, but I'll only ask a few tonight. What four indexes or programs are still with Meharry?
Well, we're still their internal medicine program, their family practice program, their OB-GYN program, and psychiatry, yeah. And they also have a dentistry program. We don't count it as a hospital, but it's also attached to us. So their oral maxillofacial surgeon program. So we have, I think we're tied to all of their residency programs in Nashville.
Okay. Second question, the legacy payment. Can you tell me what that is again? Can you explain that one more time?
I guess, I can't, probably a grizzled veteran of Metro Finance would have to help you with that.
Okay, okay.
But honestly, many years ago, probably 10 or 12 years ago, there was the hospital authority that was created, and it owned both the hospital and what was the Bordeaux Long-Term Hospital at the Bordeaux site. I don't know how long the relationship was where the hospital authority had responsibility for that, but then shortly thereafter that the Bordeaux eventually was closed. I think hospital authority only had that function for a short period of time, but I'm going to assume that Metro didn't have a place to keep paying those legacy costs for their pension people out of, and so it got assigned to the hospital authority. So even though we don't never employed those people, it is a 2.4 million impact it's the first 2.4 million out of our subsidy annually, I guess I would call it.
Okay.
Okay.
I'm learning.
Okay.
Okay. Do y'all have any patient data? Like what's the average number of patients that come through there a day or a month, year?
Yeah, there's a few different things, and I know we send them to council, but we could send them to you guys directly.
Please.
Because we do a monthly financial report that we give to the board, and it's actually out there on a public drive if you wanted to pull it down, and it'll show you, like in an average month, we average about 45 to 50 fannies in a bed, I guess I would call it, in the inpatient hospital. And then we have about 2,500 emergency room visits a month, and that's where most of those inpatients come from. We also have about 4,000 clinic visits a month at our location, main hospital, plus the Charlotte location or Midtown,
I
plus.
think a better way of looking at the clinics is the ambulatory clinics. There's usually around 300, 350 scheduled per day.
Yeah.
That comes in. And Bruce described the 2,500
Emergency.
emergency, which can get you around 70 to 80 per day on average. And then the average daily census, which usually is going to run in the 40s, mid 40s. And those are the volume metrics
And we still deliver with Meharry, about 400 babies a year
a
too.
year.
Okay, I didn't realize there was OBI.
Yep.
Okay, last
yeah.
thing. I had the great privilege of walking with Dr. Webb. Can you talk about the food pantry? I was so impressed with the food pantry.
That's
and
his baby.
Let me tell
And
you,
I'd like to let everybody know about it.
I'll tell you something about the food pantry. It started off,
Food pharmacy.
I'm sorry, food pharmacy. Food pharmacy.
Sorry.
I was about to say, it started off as a volunteer role that I had in Memphis for a number of years on the food bank. I served on the board for about 14 years. We delivered about 20 million pounds of food a year across Arkansas, Mississippi, and Tennessee. And one of the things that I recognized was that we were giving people food, but we were basically just filling their bellies. And as a healthcare leader in that community, it concerned me that the sodium and the high content of carbs and things that were going to that population was really not helping them. And so we transitioned to, instead of raising food through food drives, we raised money to purchase food from the major food institutions where we could get the foods for pennies on a dollar, and we purchased healthier food. And then it occurred that what if we were to treat the food truly as medicine? As I came to Nashville General and worked with a team here, and so we started to work on getting a framework together for providing food to individuals that would work towards improving their health conditions. And so we called it the food pharmacy. And we set it up like a grocery store. You saw it. It has the coolers for the fruits and vegetables and shelf-stable food. We even have an area for high-caloric food for our cancer patients because as cancer patients struggle with food insecurity, they're not able to maintain their weight. They have to come off of their treatment regime, and that puts them at risk for mortality. So we increased our cancer survivorship rate by having that aspect of the program. I did not anticipate that. But as far as the food insecurity, there's about 12 to 14% of the population that will struggle with food insecurity. And the key is that if an individual is indigent, doesn't have insurance, then there's a high likelihood that they're also not going to have access to adequate food. If you do not get them food, then you're going to pay a much higher cost for their health care. So the other side of this, the strategic side of this is I would rather get you food, which I can get through Second Harvest and through other donations and contributions, and we can provide that food to you. We'll make it healthy. You can get it, and we'll even teach you how to prepare it and educate you on your health condition. But the outcome is you're going to spend less time in the emergency department or in the ICU. 5 to 6% of your patient population will consume 60 to 70% of your resources. And so that principle drives that concept is it's a win-win. Patients healthier, it's the less cost to care for them. So we just pushed those resources into the food pharmacy, and people love it. The concept has received national attention. Even the New York Times has done an article on it, and so it works. And it originated here at your own Nashville General Hospital. So that's the whole story behind it.
Thank you for that. Councilmember Webb, do you have any other questions? All right, Councilmember Nash, you're recognized.
Thank you, Madam Chairman. Great program. I remember my tour through the facility. When we met, when I first got elected, there was a little bit of a discussion about, I know when we were negotiating, we had forensic accountant look at the books, city, and you mentioned that most cities are getting out of the hospital business. And you gave me a lot of good reasons why that was not a good idea. And truly, you've become an iconic part, Nashville, its fabric. I don't see the city having you go anywhere. That said, Meharry also is, we are so fortunate to have this historic Black university, world-renowned for the education of Black doctors, minority doctors, and treating people in need. And to follow up a little bit on Councilmember Evans, Chairman Evans' question is, I am so glad to hear, because I had also heard about some of the tensions that occurred. And boy, when we've got two of these iconic institutions led by eminent doctors, people that have such great respect throughout this community, not getting along, that's kind of sad to hear. And I'm so glad that I'm hearing tonight that you're all trying to work through some of that. We want you to work together in the best way possible for your institutions and for the city, and I appreciate you addressing that issue.
Thank you.
Thank you, Councilmember Nash. Do we have any other questions before Council Lady Toombs and I dig back in? All right, and Councilmember Nash, I also enjoyed my tour of the food clinic. I had a little bit of a different tour of Meharry, not Meharry, but of Metro General, as I often share. General Hospital saved my life. I spent 2 weeks in the hospital. I believe it was 2 years ago now. And I'm super thankful for General and their services to our community. So thank y'all so much. I do have a couple of questions, and then I'm going to kick it back to Council Lady Toombs to maybe close us out. And I'll try to be brief, as I know that hour has is long spent. My first question, you talked about rosters from Meharry costing 1.1 million. And if I understand correctly, Meharry did not provide rosters in time to you all, and that precluded you from being able to cash in on 1.1 million. Can you talk about that a little bit? Like, one, how does that happen? Two, what's the remedy? Three, how do we make sure it doesn't happen going forward? And four, who eats that cost?
First of all, like I said earlier, it is a new program for the state to distribute that money, the state GME money. Graduate medical education is what GME is. It was the first time in 2023, historically, Tennessee paid resident medical education costs to the schools. Where the school and the hospital were related or the same, like a Vanderbilt or so forth, it was less of an issue. But in those places where the medical school and the hospital were not related, the federal government pressed upon the state to follow what the other 49 states do and pay that money to the hospitals and not to the schools themselves. And you guys know we have a PSA, a Provider Services Agreement with Meharry, and it stipulates in writing what we pay Meharry for their residents and for some other services. And that's really important because in Medicare and federal regulations, you can't pay private medical entities just because you want to pay them. It has to be in writing because it's anti-kickback. I'm not paying Meharry to just admit their patients to the hospital. And that's true for any hospital in the United States. So it has to be in writing, and it has to be a written contract between us with specific amounts. So so keep that in mind. In 2023, we had nothing to do with it. The state made that change, and we did get the first year based on Meharry's historic resident numbers that they had provided directly to the state. Meharry has about 120 residents. About 45 of them are attached to our hospital. Others go to different parts of the state for training. So we don't even have half of theirs. And so the state now pays GME only for primary care residency programs. And so we have to have the list of each physician resident in those programs with socials and all that sort of stuff to send to the state, and then they verify it independently. And then that's how we would get the 1.1 million. It has to be done before the year starts. And I'm just telling you, I think Meharry had been doing that for years, sending that to the state and but we couldn't get it. We tried diligently to get it. We don't know if they were upset about the fact that we got money the first year. We don't really know what the reasons were, but we can't produce it ourselves. And we had a few of the programs, but not all of them. And we needed to submit the full roster for their primary care residency programs in order to get the funds. And so we were unable to get it. We did finally get it in December, but it was 5 months too late. And we asked the state, would they revisit it? And they said, no, that 1.1 million was already distributed to the other residency programs in the state. So per Dr. Webb, we have had a couple of good conversations, meetings with Meharry, their new provost and senior VPs. And I have in my hands right now the roster for the July 1, 2024 residency programs in primary care, and I will be submitting it in the next week or so. And our friends with the state and with Tennessee Hospital Association believe we're in good shape to be back in that number again. I can't say it's going to be 1.1 million, but that's what it was 2 years ago. So I'm banking on it being the same. But then in order to share any of that with Meharry, there has to be an amendment to the PSA to update those numbers. And I'm not sure why it seemed like a simple thing to modify, but it is difficult. There have got to be reasons on their side that they don't want to open up that agreement. But we're just talking about the residency piece of it specifically. And we need that in place before we can even share any of those funds with them.
Okay, thank you. I would hope that, I'm thankful that you all are working on something going forward and that you have it in hand for this year. We just need to make sure that that doesn't happen going forward because it's a lot of money and, we definitely need both of these wonderful, amazing, successful institutions to work together for the best interest of our city. So I would hope that you all are able to work together on that. My next question is about the private security for 1.3 million. And I know you explained the history of why that went from the sheriff's office to now private security. Have y'all revisited, what the cost would be if y'all worked with the sheriff's office, on this? And then I also wanted to be clear, are you saying that we are paying the sheriff's office that 700,000 or whatever you said? Are you saying that we're paying the sheriff's office to provide the service to y'all, but y'all aren't getting it, so you're having to do a private security?
No, the services were not, at one point, they were providing that service to us, and we were getting the funds, the 800, was it 800,000?
Yeah, it was 800,000 that was
Yeah.
transferred.
And so that went away, and then we had to hire a firm. So now we, out of our budget, pay for the security firm,
Right.
but we still provide the care at no cost,
To the Metro jail and so forth.
and to the sheriffs.
Yeah, to the sheriffs, right.
So it's kind of an unequal trade there, and it would be nice to create some equity in that going forward, especially if we're going to be experiencing these kinds of shortages in the requests that we're making.
I'm sorry, I don't understand. So they were providing security for y'all, and y'all were providing health care for them, and now they're not providing security for y'all. So why are y'all still providing health care for them?
Because we're nice.
Nice don't cut it when you're talking about $1.3
Yeah.
million, though.
It's
That's not the real reason.
I don't
But
know.
I think it's something that we do need to take a close look at.
Okay, yes, if we could please revisit that, and we can also present that question to Sheriff Hall when they come. I believe that maybe tomorrow when they come. So, because that's definitely something that we need to figure out that needs to be more equitable. You mentioned that y'all have challenges retaining doctors as opposed to recruiting doctors. Can you speak a little bit to those challenges? I know you said one thing was just being cognizant of like who y'all are actually like recruiting to come in, but what are are we seeing any other patterns or challenges for retaining?
No, we're not really having problems retaining physicians.
Nurses.
It's nurses
Right.
that we have problems with because they're being lured away into the higher paying contract jobs that started during COVID, and it's still a part of the culture that if you're getting $35, $40 an hour in in an area, in an environment, or in a city, and you can go to another city as a traveler and you can get $70 to $75 an hour, and especially a lot of the young nurses who don't mind traveling, that's what they're doing. And you can understand that that is a very attractive package. You get to see new places, you're not attached, and you earn that kind of money. So it's a very difficult challenge for a lot of hospitals because those organizations that are recruiting those nurses into those contract arrangements are still very active.
Thank you. I have two more questions. As far as the hiring of the doctors, because I know that there was a slide that talked about some, I guess, concerns with Harry not doing some hiring, so then y'all having to kind of backfill and do hiring. What is the agreement between y'all and Meharry? Who's responsible for hiring those doctors? Is it Meharry? Is it y'all? Do y'all have to come to an agreement, or how does that work?
Well, the reality of it is that we're an academic medical center. Meharry is a medical school, and they hire physicians to teach, train, educate. They see some patients, but that's not their priority. We, on the other hand, hire doctors to full-time see patients. We do allow them to work with the Meharry residents when they're in the environment to educate and help to train them. So they're two very different institutions. That's just the way it is when you have an academic medical center, you have a medical school, and you have a hospital. And again, we can't hire doctors for them, and they can't hire doctors for us because of the utility of the scope of the services that we're looking for. So it's unrealistic to say, well, why don't you all just jointly hire physicians? You cannot do that. It just doesn't work. It's not even realistic.
Okay, thank you, thank you for, thank you for that. Is that part of y'all's agreement, or is that just kind of the reality of how it shakes out?
Well, I think the agreement that's now over 30 years old was probably a bit idealistic in the way it was stated. And the reality shortly after that set in that there are some opportunities where you can share in the hiring of a physician. And in some cases, we rely on revenues that are generated. The revenues that we generate, they're generated because these physicians are working full-time in our settings. If we take those physicians and say, well, you only need to spend half of your time working here and half of your time you could spend over there, you'd be giving us a much bigger subsidy to keep the hospital open. And so basically, you would be subsidizing something very different, which would be an ineffective relationship that just is not going to keep the hospital or the medical school viable.
Thank you for that. I understand what you're saying. I'm trying to get an understanding of, it sounds like the agreement that was previously entered into is probably not working for y'all now. So are there like conversations of like updating those agreements, or where are y'all with that?
Yeah, I think over time, it's been realized that that's not realistic. And that's what we're doing now in our regular meetings with them, is working through where there are realistic opportunities. I think there are a lot of things we can do differently to help to support the medical school and its mission that are really and more collaborative in nature, and not just something that you're trying to force that goes against the grain of the natural responsibility of the two institutions. They've got to teach students. We've got to take care of patients. Where we can work together is a space in between. And if we try to force that into one area that says the people that are supposed to be seeing patients are just going to have to go and teach students, again, you're disrupting the natural rhythm of the two institutions, and one of them or both of them will not survive. It's kind of like splitting a baby in half. It just won't survive. But there is, and medical schools and hospitals do this all over the country. You find where that working relationship best benefits both organizations, and that's where you put your effort. And so we're working on that. We're going to continue to work on that. our goal is to maximize that relationship.
Thank you for that, Dr. Webb. And that just kind of brought up another question, and I promise I'm trying to be brief, y'all. Are y'all looking at other models where the, I guess, the teaching hospitals and the, a hospital that's providing care and then the teaching institution are working together? Are y'all like looking at other models to maybe get some inspiration on like what's working in other places?
Yes, we do have individuals that are on our team that have spent time working in other places. We have a chief medical officer, Dr. Williams, who has consulted with a lot of major institutions. He's working with us. I think one of the biggest opportunities that we have is to create the build of a state-of-the-art teaching hospital, which would be conducive to that relationship. There's a lot of retrofitting and trying to make things work as they are now. The training in the environment for teaching is certainly not optimal where we are. And years have gone by. I had the opportunity to attend the ribbon cutting of the new Frist Belmont Medical School. That is what a state-of-the-art teaching facility looks like. And a lot of those attributes could be captured in the hospital that we would build and design. So I think it would be a good idea for the city to really take a close look at the opportunity and what it could do for both institutions. I think it would attract more medical students for Meharry, and it would attract more patients for the hospital. Those two would make both those institutions more fiscally viable. And I think the relationship will take care of itself. We're going to do that anyway. But the facility would certainly add a whole different perspective to how financially viable those two institutions could become in a state-of-the-art setting.
Thank you for that, Dr. Webb. And then now the just kind of winding down on the last two. I know there's been some mention about delays in payment to Meharry, and I believe there's also some conversation about maybe money owed to Vanderbilt. And if y'all could just kind of speak to that so that we're all on the same page, that would be helpful.
Yes, I will.
You want to do it? You defer to me?
Yeah, no,
Just
I'm not going
'cause-
to defer to you.
Oh, go ahead.
I want to speak to that.
All right.
Because the issue is that we have payments scheduled on a routine that we tend to pay individuals. Now, that could be a 30-day, that could be a 60-day, that could be a 90-day. Usually one of those is going to fall in one of those ranges. It is a matter of managing the cash flow. We are going to make sure that we are continuing to work with them to keep a payment routine in place. In our meetings with Meharry, we're going to investigate the payment routine for them to see how we can work towards improving on that and where they need to be in order to be more, fluid with their flow of, with their cash flow. And I think there's some opportunities there that we can work with them. There's not a magic wand that you can wave, and hospitals are notoriously late pays for late paying because it's a way of managing cash flow. I've worked in other systems, and you don't submit a bill to a hospital and you get paid the next day. You're going to be put on a pay cycle, and that's how it's going to work, and that's how those cash flows are managed. You don't have to be a CFO to understand that. And I think if there are some issues and concerns there with Vanderbilt or with Meharry, then we need to just have that conversation and work through. We've already had conversations with Vanderbilt, and I've spoken with the CEO there myself. And we have put a proposal on the table for the payment scale, the payment cycle. I assume we're continuing to work with that. So I think a lot of it is about things that you have heard. Some of it came through the board meeting, which is probably not the best place to be having those conversations. But I think you've heard some of that. I think it gets blown into a bigger issue than it actually is. So,
Thank you, Dr. Webb. My last question was just about that 5% increase that employees are getting year over year. Can you explain, like, is that compounding? And I did some quick math while I was sitting here. So if somebody makes 40,000 and they get 5%, that's an extra 2,000. So then they're making 42,000. Are they getting an extra 5%? That's 2,100. So now they're making 44,100. Or are they just getting an extra 2,000 every year on that base of 40,000?
It's compounding, Council Lady, Madam Chair. So if you make 40,000 and you get a 5%, it's 42 this year. And if you get 5% next year, right, it's going to go to 44.1. So it compounds just like a normal salary. So it's not paid like a bonus. It is actually becomes part of your base.
Okay, so this is, in essence, they're every year, they're getting a 5% increase on what they were making, and that comprises of both cost of living.
That's all we have, yeah, just one number.
Okay, and is that 5% guaranteed every
No.
year?
And we haven't even had 5, but we've had a couple of years where it was 2 or 3% at the hospital,
I
just
think
since I've been there.
do you mean, is it based on performance? Is that what you mean? Or,
No, not, is
Okay.
it based on performance? Like, do we know that it's gonna be 5%? But you said that some years
It's
it's 2 or 3.
budgeted as 5%, but in some years it has been less than 5%. But Metro has had years that were less than 5%. We try to track relatively close to Metro if we can, just to be good stewards. But it was 5% last year and planned for 5% this year.
Okay, thank you. And Council Lady Toombs, I know you had some extra questions, additional.
Thank you, Chair. I just have two questions, but I did want to heap on my praise before I do my two questions. Two of my children were born at Nashville General Hospital by choice because it is an excellent hospital. So I want to thank y'all for the work that you do. Two questions. So I know that last term, the council like readjusted the rent for Meharry and it went up. Is that, I thought it was higher than $4 million. Is that accurate that it's 4 million?
6.2,
I thought it
but
was-
I believe we're still covering the 4, right?
Okay, and then Metro covers the difference. Is that right?
I can't speak to it. It's not paid out of our subsidy or support. The
Okay.
4
We do
is.
know it was committed to them because obviously it was in the press conference. So it was committed, but we're only committed to the 4.
Okay, okay. You have, I know you just recently opened a clinic on Clarksville Highway. Do you still have the one on Charlotte?
Yes.
Midtown. Mhm.
So is that included in like your repairs and maintenance and your other?
Luckily, those are new enough that there's not a lot of repairs and maintenance yet, but they would be. It's all part of the system, which is what we
The staff
present.
for those clinics
Yes,
are included
they're
in
in
your-
there. Yes, ma'am.
Okay,
Well, we
That-
don't have triple nets.
Not at
those.
those locations.
thank you, Chair, that's all.
Thank you, Vice Chair. Do we have any additional questions? Dr. Webb and Mr., I feel like I'm
You
saying
did
your.
good before.
Did I say it
Naramore.
right?
Naramore,
Naramore.
that's it.
Mr. Naramore, Dr. Webb, thank y'all so much. We appreciate the services that y'all provide for our city and for our constituents and for us as city employees ourselves. We appreciate these services that y'all provide for us. So thank you all so much for taking the time to be here. And with that, today's budget hearing is coming to a close, everyone. We will start back again tomorrow promptly at 4 o'clock. And we have on the schedule tomorrow, we'll start with fire and EMS, followed by the sheriff's office, the police department, and then the public defender's office. And with that, our meeting is adjourned.
This has been a service of the Metro Nashville Network. If you would like to see this presentation again, or for more information on this and other programs, visit nashville.gov.